Bismillahirrahmanirrahim. Uh, Hello, dear students. Can I have a confirmation if my audio is clear?
Yes.
Okay, that's good. And I will just share my screen and see. Please, I will also need a confirmation if my screen is visible.
Yes, doctor.
Okay, that's good to know as well. We'll give, as we go around in the next 2 or 3 minutes, I will allow in these latecomers, right? And first of all, my apologies for starting half an hour late. We had a sessions with year four that kind of just pushed forward, so I couldn't start at 11, and that's the reason for the delay in our session, right? Okay. Okay. So if I can make a start, Bismillah ar-Rahman ar-Rahim, what we are going to do today, again, I would prefer it to be more of an interactive discussion rather than a one-sided lecture. So can I please request the student and get a commitment from them that they will be interrupting me, you will be asking questions, you will be answering the questions that I put forward. So we are going to convert it into an interactive session rather than a one-way discussion. Do I have that commitment? Inshallah, good. So
Yes,
we'll
doctor.
okay, excellent. So the learning objectives for today's session, we want to be clear on what we actually want to learn from this session. Just let me admit the student, get back to our session. So we want to comprehend and we want to discuss and try to understand what is the bio, psycho, social model of cardiac illness. So we have three aspects of this model, which is bio, psycho, and social model of cardiac illness. We will understand the application of this model in actual clinical practice, how it is done, how this model is understood, and then how do we apply it. And we'll also touch on the importance of the doctor-patient communication. Why is it important? Not only heart disease, but actually for all type of diseases patients present with. We will try to discuss the importance of what the patient's side of the picture is, which is usually ignored or not emphasized as much. What is their questions? What are their perceptions and their concerns, and how these concerns, addressing these perceptions and concerns, help to manage not only cardiac diseases but generally diseases as a whole. And we will also try to understand the concept of cardiac rehabilitation and how it is linked to this bio, psycho, and social model. So, are we clear about? Naturally, these points will be clarified as we go along, but we do have focus points that we want to cover for today's discussion, right? So, we want to understand the bio, psycho, social model. We want to understand how it can be applied. We want to understand the importance of communication between the doctor and the patient. We want to understand and try to have a look at what the patient goes through or what goes through the mind of the patient whenever they have a disease generally and cardiac disease as a whole. We will try to understand the concept of cardiac rehabilitation and what's its importance, right? Okay, I think we'll, okay, right, fine. So any question at the moment regarding the learning objectives?
No.
Okay, good. Okay, we will start off with the hadith of Rasulullah. It's from Sahih Bukhari and it was narrated by Nu'man bin Bashir. The hadith, the translation says that surely there is in the body a small piece of flesh. If it is good, the whole body is good, and if it is corrupted, the whole body is corrupted, and that is surely the heart. So even in our divine guidance from our Prophet Rasulullah, we understand that the heart has a very central position in not only physical disease, but we will go on to understand that it also has an importance in spiritual and psychological aspects as well. And the newer studies and newer discoveries have actually raised a question on whether heart is the seat of Basira and Hikmah as it is taught to us in our religious scriptures, right? Now we have a patient. We'll start off with a patient, an example of a patient, and the patient is a 55-year-old gentleman who works as a clerk in a ministry or as an administrative staff in the Ministry of Education. He recently had an acute myocardial infarction. He has long-standing diabetes, hypertension, and is also a smoker. And during this evaluation after the myocardial infarction, he was found to be dyslipidemic. So a 55-year-old male who is a smoker, hypertensive, diabetic, and was found to be diabetic, having dyslipidemia as well. And he works as a staff in the Ministry of Education. And we know recently that the Ministry of Education was in the process of restarting on-campus activities. So there was a lot of work and lot of work stress during this time. And this gentleman had an MI. The question is, what caused the myocardial infarction? What do you think, students? What do you think caused the myocardial infarction in this patient?
Dyslipidemia.
Okay, you want to blame dyslipidemia? Anyone else has it? You think it's very good. So there's more than one factor. So what could be?
Ischemia.
So it was ischemic heart disease. So ischemic heart disease caused so a narrowing of the coronary arteries caused it. Yes. Anyone else? What caused the myocardial infarction? It's a very straightforward question, and
maybe atherosclerosis get ruptured or get complicated, so the artery gets
very
blocked.
good. So it was a rupture of an atheromatous plaque, and that caused the MI. Yes. Any other ideas? Did the work?
Myocardial arteries. The coronary arteries blocked.
Yes, coronary arteries blockage, which was due to atherosclerosis or a blood clot that caused it. Yes. So we see that we do have. What about diabetes? Could diabetes have contributed?
Yes.
What about his smoking?
Yes, it may be.
Yes.
So is there a simple answer to the question what caused the myocardial infarction? Can you have a simple, straightforward answer to it?
No, doctor.
No, we understand that the situation is much more complex than this, right? And it's not a single factor that you can pinpoint that caused the myocardial infarction, right? So we could look at it pathologically and we could say that this patient is 55-year-old, he's diabetic, he's hypertensive, he's a smoker, and he was having atheromatous disease of the coronary vessels. And this atherosclerosis, someone said that atherosclerosis caused the MI. Well, atherosclerosis cannot directly cause the MI. Why do you think the atherosclerosis cannot cause the MI?
Because it's not the atherosclerosis itself, but the complication that happen after the atherosclerosis.
Very good. So specifically, atherosclerosis never causes an MI. It can cause angina, stable angina by itself. When the patient, there is a narrowing, fixed narrowing of the coronary vessel, the patient at resting condition has no problem with ischemia, but once they exercise, the oxygen demand goes up and this narrowing does not allow enough blood to be supplied to the cardiac muscle, and that can cause stable angina, exercise-induced angina. But an acute myocardial infarction, you would need the atheromatous plaque cap to rupture, and this, what could have caused this rupture?
Thrombus formation.
Stress could cause the rupture. Yes, a bout of hypertension could cause the rupture. Maybe he was doing binge smoking during the stress period that could have caused the rupture. So you need the rupture, and then the rupture would cause exposure of the tissue to the blood, and it would have activated the clot formation, and the clot rapidly occluded the remaining lumen. How much time does it take to form a clot in the vessels, within a vessel?
Minutes?
Yes. How much time does it take for a blood clot, for the clotting cascade to become activated and form a clot within a blood vessel? It's less than minutes. It can sometimes take a few seconds or even fraction of a second, depending on the cascade is very quickly, in the process. So you see, if I think of this, then some people might say the atheromatous plaque caused the rupture. Some people caused the MI. Others would say no, it's the clot that caused the MI. The plaque couldn't have caused it. Some people would say it was the rupture that caused the clot to form and that caused the MI. So we need to understand that you cannot pinpoint a single event in a complex disease that could be attributed to causing the event, right? And why is it important to know what caused the MI? Why is this question, the answer to this question, important?
So that we know that what is the factor, so we'll only focus to treat that factor.
Very good. I would like to modify the statement to some extent. You want to know what went wrong that caused the MI, so you can have a response to it, or you can have a management plan, right? And management plan, if someone thinks atherosclerosis is the cause, they would start the patient on statins. If someone think that the clot is the cause, they would start the patient on antiplatelets, right? People would say it's the plaque rupture and the stress was the cause, they would maybe take steps to reduce the stress on the patient. If some people think that it was the smoking that had contributed to the plaque rupture, they would ask the patient to stop smoking. So depending on what you think is the cause of a disease, you will plan a response to that in management accordingly. So it's very important you like to basically answer the question effectively and comprehensively on what caused the cardiac event or what caused the cardiac disease in order to treat it or to prevent it, right? So let's say we have this patient, he will report to the emergency. What do you think they will do with him? A patient with an acute MI in the emergency?
Maybe do ECG immediately to know.
Very good. They will do a number of investigations within a few minutes, ECG, cardiac enzymes, and echo. And let's say this patient, it's diagnosed immediately that he has an MI, he's shifted to the cath lab, and the cardiologist comes in and he puts in a catheter and opens up the obstruction and removes the clot and then puts a stent over there, right? And that's how his myocardial infarction got cured or treated. Yes. Do you think that's the end of the management? Do you think that's what's required in this patient?
No, there should be post-care medication or something like this.
Very good. So he is admitted to the hospital. He's given medications to further antiplatelets, antihypertensives, maybe statins for dyslipidemia. And do you think that this patient is going to be cured and is effectively going to be managed for his MI at this stage? And then he's discharged after 3 days. Is that the end of the story?
No, actually, no.
Actually, the job has been done well. He has been cured of the problem that arose, and it was a myocardial infarction. We could say that he was cured of his disease, his myocardial infarction. But there is this concept of care. What is the difference between cure and care?
The prevention and treatment.
Very good. So if this physician treating the myocardial infarction is one of the aspects of patient management. It's curing the disease. But we want to look at a more comprehensive approach, which is called care approach. And we would want to look at all the risk factors that this patient has. He's diabetic, he's dyslipidemic, he's a smoker, he was under a lot of stress, he doesn't exercise very frequently, he's having a sedentary lifestyle. And actually the care and comprehensive management would be to address all these problems and offer solutions to these problems as a whole. So you could cure a patient of myocardial infarction, but that will not be sufficient. You need to care for a patient as well. As a physician, would you like to be a physician who's good at cure or a patient who's good at care?
Both of them.
You would want to remember that care is also a comprehensive approach to patient management should be present, and you should care for the patient as a whole, and that's what the patient actually deserves. It's not just curing a single problem. Now, when we think of this patient who had a myocardial infarction, what was his problem? What was an immediate problem? It was a clot in the vessels. Yes, it was a clot in the coronary vessel. But this coronary vessel did not have a clot because of a single factor. There were so many factors that resulted in this clot at this particular time, right? So this basically, if we think of it, the patient had the coronary artery affected, which was the was part of the patient's vascular system as a whole, which was being affected by the 4 factors of hypertension, smoking, diabetes, and dyslipidemia. And the coronary closure did not affect only the coronaries, but actually caused damage to his myocardium. So we need to understand that the organ that gets affected, or the disease that occurs, is not occurring in a closed system. It is occurring in a patient as a whole. Can this patient have complications that are not related directly to the heart in this patient, in this acute myocardial infarction? Can you think of the complications that could have occurred in the patient?
Yes.
Yes, what complications could have occurred?
Yeah, embolism or something like peripheral. Or
Very good. So the patient could have actually thrown off a clot from the left ventricle because of myocardial ischemia and infarction, because the left ventricle isn't contracting properly. You could have had a clot thrown into the cerebral circulation. What would happen if a clot ends up in the cerebral circulation? The patient would have had a stroke. Yes?
Yes.
So the patient would end up having a myocardial infarction, which was actually started off with a clot in the coronaries, caused a clot in the left ventricle because of left ventricular dysfunction, and this clot was thrown into the cerebral circulation, and now the patient has developed dense hemiparesis and aphasia, for example. So we need to understand, whenever something goes wrong or there is a disease process in a patient, it is not occurring in an isolated system. It is occurring in an environment that includes the patient, the whole patient, and we should be mindful of that, right? So we could have looked at only the vessel as the cause of the problem. We could look at this problem as being in the context of the cardiovascular system. We could look at this event as affecting the whole body, but we need to understand that it's not just the patient's body, but the patient is in an environment, and all this environment is going to affect his body, and his disease is going to affect his environment. So if we think of it, this coronary clot, small clot in the coronaries, is existing in the heart, which is existing in the patient's body, but this patient was existing in an environment which was made up by work, his healthcare, his relationships with his family members, his family, his dietary habits, etc. And in addition to that, this environment, this patient is also having a psychological environment that makes him think. He's thinking about his illness. So if you think of this, again, going back to the atherosclerosis with a little clot, the picture is not that simple. The patient is living in an environment, and this body is the biological model, the biological aspect, his body. His environment, as far as his family, his healthcare, his work style, is the social model aspect of this model, and his thinking about the disease or his background is the psychological model. So do you see that there are 3 layers or 3 aspects of this disease? One is the biological model, which is the clot and the occlusion and the ischemia and the heart and his body. Then is the social model, and this is basically his interaction with his environment, social environment, his healthcare, his work, stress, his family, etc., etc. But in addition to that, there's a psychological aspect of this disease as well, that is basically depending on his thoughts and his attitudes and his concerns about the problem. So do we have a basic understanding now of what a biological, social, and psychological model entails? Is that clear?
Yes.
Yes.
Okay. So do you think a good physician will only focus at the biological model, thinking only of the atherosclerosis and the clot, or would it be useful to think of this patient's social environment, or it should be important that you also think about the psychological aspect of his disease?
Of course, you have to take care of all of these factors.
Excellent. So this is the difference between the cure and the care approach. The cure is usually limited to correcting the biological problem that has occurred, whereas a care is thinking of the patient as a person, as having a specific thought process, psychology, as well as this person existing within the society and addressing all these problems in that approach, right? So we need to understand there is an approach. You need to cure the whole human or approach the whole human rather than only affecting the, approaching the disease. Is this concept easy to comprehend? That you do not just take care of the disease, but you also take care of the person as a whole who's affected by that disease. Is that clear?
Yes,
Yeah.
doctor.
So there is a saying that good physicians treat diseases. Excellent clinicians treat persons, peoples with those diseases. Yes. So we want to all keep remembering this concept that it is not enough to treat the biological problem in the patient, but we should also keep in mind his social environment and his psychological environment and try to basically approach all of them. So we have the example of a cure task-oriented behavior. This is curing the problem and having a task. But the care approach is having an understanding and empathy and more interaction with the patient. So we are now in an era where we are basically going from cure to care approach. So curing the patient is not enough. You need to care of the patient, take care of the patient as well, right? So there have been studies in which patients have been asked to give their idea on what would they like. Would they like an effective solution to their biological problem and get a cure? Or would they like to be cared for as human beings? And overwhelmingly, the patients stated that they would like to be cared for rather than cure, only cure, right? I'm going to ask you a question, right? So a patient comes to the cardiac emergency. The diagnosis is that this patient is having atrial fibrillation without complications. What would be the patient's complaint? What would be the patient's symptom with this atrial fibrillation? What would be the symptom of atrial fibrillation?
Maybe problem with breathing.
It could be a problem with breathing. Let's say the patient with atrial fibrillation has got a very fast, irregular heartbeat. How will the patient feel this?
Anxiety.
They will have anxiety. They will have palpitation. Yes, palpitation is a symptom in which patients has an uncomfortable awareness of their heartbeat. Yeah, so they will come with palpitation, and this is the reason that brought them to the hospital. And you have a very effective cardiologist, okay, who sees him over the night, starts on some basic treatment. Atrial fibrillation by the morning is gone. Patient is stable. And in the morning, the patient comes and discharges the patient. The physician comes and discharges the patient and tells them, be prepared for more frequent incidences of atrial fibrillation. It's going to occur again and again. That is because you're getting old. You do not have to come to the cardiac emergency each time when you get these episodes, right? Okay, and that's it. This is a packet of medication. You can go home, right? Now, what is the model being applied here? Is this an example of cure? Is this an example of care? Or is it a combination between cure and care?
Cure.
What's missing in this patient's approach, in this physician's approach? Well, he didn't communicate with the patient. He didn't ask the patient whether the patient has any questions. I mean, just simply telling him, I mean, he told the patient, use the medical terminology, atrial fibrillation. The patient has no idea what is atrial fibrillation. Yes? And then he tells him that you're going to get it more frequently. And the reason is because you're getting old. And the patient says, my brothers are older than me. My family, I have elderlies in my family. They don't have this problem. Why am I having the problem? Right? Now, if you look at the situation, that the doctor has actually taken care of the problem. He has sorted out the problem. He has managed the patient effectively. He has cured the problem. But where is the care aspect in this patient, in this approach? Do you think this patient will be a happy customer leaving in the morning? Will he be a satisfied patient?
No.
No. That's it. And so we will again reinstate that we will, of course, always look at the cure and care approach and not just depend on one of them. That's one thing. Secondly, the physician has just looked at the biological aspect. He has said, okay, this patient is having atrial fibrillation. He has done the basic tests. They're all normal. And he believes that maybe the old age is causing the problem. The patient is 76 years old. So he has applied the biological model effectively of what's wrong in what's disease, what's the pathology. but he has not gone on to apply the social model or the psychological model. For example, the social model was does not know that this patient lives all alone because the patient's wife died a few weeks ago. So this is a social issue. Who's going to take care of this patient if he has another episode, or who's going to make sure that this patient takes the medication regularly? He did not find out that the patient has mild Alzheimer's at the moment. There is a bit of dementia, and this patient is not going to be regularly taking his medication. That's a social aspect, right, of this model, which the doctor has completely missed. The psychological aspect of the model is the patient is worried that he might die alone at home. He's worried that he doesn't know what atrial fibrillation is. He did not really understand what's going on. He did not understand why did the doctor say that you can get it, you're going to continue to get these episodes, and he's worried why did the doctor ask him not to come to the emergency every time you get this episode. So you see that although the physician has treated the patient and cured the problem, but there are very wide lacunas that are remaining in the overall management of the patient. And this is between the cure and care approach, as well as there are missing aspects from the social and the psychological aspect of disease, right? Okay. Now, I can give an example of a patient. He's a 38-year-old male from South India. This is a real patient actually, South Indian male, 38 years old, and he is presented with an acute MI, a massive acute anterior wall MI. The patient is young, is 38, does not smoke. His lipid profile is relatively okay, right? His family history is slightly suggestive for coronary artery disease. But his main question is, or the physician's main question is, why did he get an MI at the age of 38? Can anyone answer this question or try to answer this question?
Maybe because of an extrinsic factor.
Okay, what are the other risk factors?
Like he is always stressed.
And what could be the stress? He's 38. What's stressful? He's driving. He's a driver, family driver, so it's not very stressful driving for him. So any ideas? Why did he get the MI? Why did he develop the atherosclerosis? And then why did this plaque rupture? And why did he get a clot that actually caused the MI? Very good. So he most of the time he spends in the days in the car seat, in the driving seat. So he's not very active physically. That contributed to the disease, isn't it? Yes. But is it normal for males at the age of 38? Is it expected for a 38-year-old male to get an MI, and that to a massive MI with no other significant risk factors?
No.
Okay, so we will need to, someone talked about stress, yes? If I told you that he's been in Saudi Arabia since the age of 22, so he's been in the Saudi Arabia for 16 years, and he has changed a number of his sponsors, but he has always been a car driver, and he's here for 16 years. Because of the COVID situation, he was unable to visit his country or his family for the last 2.5 years. That's an additional piece of information. And he's married, he has 2 kids. He hasn't seen his last child, who was born after he came to Saudi Arabia in his previous vacation. So he hasn't seen his and held the child in his arms. And he is facing some domestic stresses at home. His father has died recently. There is a problem with maintaining the household. His house, the paternal house, was being shared by everyone when his father was alive, but now they plan to sell it off, and he's trying to look for a place where he can have his immediate family, his wife and 2 kids, right? And he might have stress, etc. So if you think of it, now we understand that this patient is suffering not only from acute stress for the last few weeks. What is more significant in this patient's history? He is suffering from chronic stress of staying away from the family, working in a foreign environment, always being worried, missing his family, I mean, these are all stresses. Yes. So
Yes.
now if I ask you what caused the MI, you might have a more clearer answer. So although you say to yourself it is the ischemia in the atherosclerosis, the plaque ruptured, and the clot happened with the infarction. That's the biology application of the biological model. And you said in addition to this atherosclerosis, etc., in a 38-year-old male is because he's sedentary, he's under a lot of chronic stress. Now you applied the psychosocial model as well, right? So to deal with diseases effectively, it's a good approach to apply the biopsychosocial model. Now, can you think of the risk factors that contribute to coronary artery disease? We can go one by one. I have a request to make. We have a large student group. I would request everyone to chip in and participate rather than the fixed students that are doing it. So I would like everyone to be proactive and participate. So don't be shy. Please contribute. It's an interactive discussion. So we will like to extend the number of interactions to everyone, nearly everyone that is present in the group, right? So can I have people just one by one label the risk factors that contribute to coronary artery disease?
Can I start?
Yes, please. Everyone.
Family history.
Family history. So people with significant family history, naturally, they can have a genotype that can actually contribute to ischemic heart disease. The Southeast Asian population carries a genetic background that predisposes them to having ischemic heart disease more frequently than their counterparts in the West, right? So that's family history. Very good.
Yes.
Anyone else?
The gender.
The gender. We know that male sex is at a higher risk for developing ischemic heart disease as compared to the female sex gender, especially in the premenopausal age group. So postmenopausal, the risk becomes very similar. Yes?
Age.
Sorry, can you repeat that?
Age.
Age. Okay. Although he's not classically in that age group, but naturally with each and every year, apart from adulthood, as you go towards older age, the risk for developing ischemic heart disease does increase. Very good. We have some students who are contributing by through the chat. Actually, I am not going to, we will not try to look at that because we have a slide that we want to continue sharing. So I would request a more verbal participation if it's possible. So we have age, we have the male sex, we have, yes, stress, dyslipidemia, hypertension, smoking,
physical activity,
sedentary lifestyle. So you see, you have got very good diabetes, etc. Okay, we are very much aware of the risk factors for ischemic heart disease, but we need to understand the interesting thing is when you combine these risk factors, like let's say we have a smoker and then we have a diabetic, the risk factor is not additive in nature. It's not 2 plus 2. It's actually a logarithmic in nature, that these multiple risk factors, they multiply the effect of each other rather than add. So it's very clear that if you had a patient with one risk factor, and I mean like this, you have this dotted line, one risk factor, the estimated survival function or the incidence of coronary artery disease will be low. If you add a second risk factor, the risk will multiply. If you add a third, fourth, and so on, the risk with, as you increase the risk of these risk factors, as you add them together, the risk of coronary artery disease will continue to increase in a logarithmic way, in a multiplication way rather than additive. Okay? So, yes, please. Well, cocaine can cause coronary vasospasm in an acute state. As such, so it's more of an acute coronary vasospasm rather than atherosclerosis. Alcohol abuse basically is associated with an overall increased risk of cardiovascular events, but by itself, only taking alcohol with no other additive risk factors has a very negligible risk, but the risk is there, right? You could add them, right? Okay. Now if you then take this patient's disease, cardiac disease, and you apply the biological, psychological, psychosocial model on this patient from South India, you will be able to have a much more comprehensive understanding of what's going on in this patient. We will now say, we will be surprised, why did he have ischemic heart disease or coronary atherosclerosis at this age? The answer is that he is from a Southeast Asian background. One, he has a family history which is suggestive of coronary artery disease, plus he was under stress that accelerated the development of atherosclerosis. This is the biological model, right? When we look at the and this caused an infarction, and it caused a loss of left ventricular myocardium by death of that tissue. In the social model, we believe that he's got a sedentary lifestyle, he's not very active physically, and he's staying away from his family. And if you're staying away from family, then naturally he's either preparing the food himself or eating from outside. Both of these might not be very contributory towards his health. So if he's eating from hotels, it's not a good idea, because the food that you get from takeaway food is not very healthy when you look at its caloric or fat content. If he's cooking at home, it takes a lot of effort to cook after his duty. So maybe he's not eating properly. He's not eating the proper diet of fresh fruits and vegetables, rather than he's just focusing on certain fixed diet. That is the social model, right? And let's say that he doesn't smoke himself, but he has an elderly male in the family that he drives around. Let's say the grandfather of the family, he drives him around from one place to the other, and that person smokes heavily. That will make this patient a passive smoker. And this passive smoking is one of the social contributors to his cardiac disease. And when you think of the psychological stress, we talked already about the stresses that he's basically facing, staying away from the family and other such factors. So coming to the psychological approach, what about his own problems? I mean, is he going to be devastated? What are his questions going to be in his mind? What do you think questions come to him? What are his concerns? Yes, naturally, he has the MI once, and it's a traumatic experience and a very dramatic event. He's always going to live with the worry, what if it happens again? Yes? So naturally, this is one of his concerns. He's going to think, why me? Why did I get an MI? I'm not a smoker. I'm not obese. He's going to have this question, why he wasn't expecting to have an MI at the age of 38, right? Another question that's going to be in his mind is, can I continue to work here after this MI? Can I continue to work in this environment? How quickly can I start driving? Yes. How is this MI going to affect my overall outlook on life? What is my life expectancy? Am I going to die after 5 years? I'm only 38. Dying in the next 5 to 7 years more would mean that I'd be dead at the age of 45. I still have family commitments. I have 2 children to mentor and to take through their early life education and get them married and provide for my family. His question is going to be, if I get out of work, who's going to feed me and my family back home? So imagine this patient, he is going to have a lot of questions. Who's responsible to answer these questions? Who's going to encourage these questions to come out?
The doctor.
The doctor. So we need to be aware of this. So this biopsychosocial model is a very effective model towards dealing with patient presentations. So we understand that he has coronary artery disease, but this coronary artery disease is a result of multiple factors like biological factors, social factors, and psychological factors. And when we try to address his disease as a response, we should be aware of these factors and try to mitigate them and reduce their effect individually one by one, right? Do we agree on this? Is this model clear?
Yes, doctor, yes.
Right. Okay. Now, the easiest part of this model to understand is the biological factors and the biological model. So we say dyslipidemia in this patient, stress, atherosclerosis. That's the easiest way to, it's much more easier to apply, right? That's why doctors tend to stop at this model, because it's straightforward, simple to deal with. You treat the dyslipidemia with a statin, you prevent a clot with an antiplatelet, put the patient on antihypertensive, cardioprotective drugs. That's easy. It's easy to write a prescription, and to sort this problem out. But the more difficult thing is to think about the psychological problem this patient is facing. For example, this patient will require a behavioral lifestyle modification. What lifestyle modification would you think of in this patient that he should make to prevent further risk of coronary artery events?
To be physically active.
Yes, Roberto. Can I have a cup of coffee and a glass of water, please? Thank you. Yes, sorry. To be more physically active. Yes, he needs to be trained that he should exercise and walk regularly, not immediately after the acute event, but maybe in the upcoming future. He will have to change his lifestyle. That's one. Very good.
I think to sleep يعني well.
Naturally, he should take care of his sleep habits. He should be sleeping, and lack of sleep has been associated with increased risk of coronary events. Okay. What else?
And eat healthy.
Eat healthy food. Yeah. So you tell him, please eat food, fresh vegetables, fruits. Bring down your intake of carbohydrates and fats, etc. Okay. What else? Take care of his stress. Visit your family more often. Maybe visit instead of once every 2 years. Why not make it better if you visit them twice a year, right? Now, which part is easier, writing a prescription or making this lifestyle modification in this patient?
Writing the treatment.
Writing the treatment and handing a bag of medications to him is the easiest part. And that's what doctors usually do and stop at. Yes? Dealing with actual changes in behavior, this will not be enough by this one meeting alone. You will need to teach him what needs to be done. You will need to follow him up on the coming visit and find out how much he has achieved. And he will need further motivation and encouragement for this. Yes? But again, this is difficult, isn't it? And how many doctors do you think take up this responsibility positively?
Very few.
Very few, right? Okay. How many doctors ask the question to the patient, okay, dear, what are your concerns? What are your worries? How many
I
doctors
didn't meet.
You didn't meet any doctor. I'm sure this is one of the aspects of the biopsychosocial model or patient care that is the least practiced in our environment here. Very few doctors will, after doing their job and ask the patient, dear, hold the hand of the patient and ask him, we know you have been through a very traumatic experience. We are here to help you. We have done the best we can do as far as the management is concerned. But dear, I'm concerned about what are your worries. And you know what the patient does is he might burst into tears and tell you, doctor, my main problem now is I have a daughter who was born 2 years ago after I came to Saudi Arabia in my last vacation. Wallahi, I want the chance to hold her in my hands. I don't want to die before that. Do you think this is a valid concern of the patient?
Yes, of course.
Who's going to ask? I mean, how many physicians do you think are willing to support him on this? Not
much.
Not many. Yes. No one will look for this. Yes. But naturally, you want to give the opportunity to the patient to voice their concern. Depending on how comfortable the patient feels with you and what type of a rapport you have with the patient, and as you said, how many times you have seen the physician, the patient is a human being. His disease is occurring in a social environment, in a psychological environment. It is not just that clot that occurred. It affected his social issues as well as psychological issues, and the patient needs to be supported on these, right? For example, his sponsor might have a question, how quickly he can get back to driving. When do you think he can, after he starts after 3 days, when do you think he can start driving? Who's going to answer this question?
The doctor.
Yes, we agree that the doctor is responsible to take a decision regarding that. There are guidelines on how quickly people can drive after an acute myocardial infarction. So there are guidelines, different guidelines for different parts of the world. Generally, a patient will not be allowed to drive independently at least 1 week after an uncomplicated MI. And if there has been some complication, that period will have to be extended to 2 weeks. So what would you advise? Should he continue to drive? Should he take up a different job? Okay. I mean, so you have this health, your social support or rehabilitative support that could be thought of as well, right? So again, the doctor, as we said, cannot be overtly involved with the patient too personally, too emotionally, but naturally the doctor has to take up the leadership position and should be in a position of guiding the changes that will have to be implemented in the patient's biological model, in their psychological model, and in their social environment, right? Do we agree on this?
Yes.
Okay.
Yes, doctor.
Now, another aspect is every patient is different, right? Every patient has a different context. This was a 38-year-old male that we talked about. We had a different example. We had a 55-year-old Saudi national who had an MI working in the Ministry of Health. He has a different context. His questions and the approach towards him might be slightly different. What about the difference between a male and a female patient? Do we deal with them in the same way? I mean, when it comes to cardiac disease?
Of course, no.
Yeah, I mean, we'll address this in a way. So remember that any approach that you make, like changes in lifestyle modification, for example, would have to keep in the context the patient's age, gender, occupation, social support, family support, and their psychological context, their psychological thought process. It will have to be made. So changes in lifestyle have to be tailored individually to the patient. Medications have to be somewhat tailored, but we follow the same model. We have a very simple model. After an MI, we have a patient on a antiplatelet, cholesterol medication, antihypertensive. If required, the patient blood sugar should be controlled. That's a much more simpler approach. But for patients, when you come to their lifestyle modification, the approach has to be tailored individually. A 70-year-old female, elderly male, would have a very different target for regular exercise when you advise her as compared to this 38-year-old male when you talk to him about what type of exercise and how frequently he should do it. Do you think that the advice will be different? Naturally, it will be different, yes?
Yes.
Okay. So when we talk about lifestyle, we will first of all, in a patient, establish the overall cardiovascular risk in this patient for further events, depending on the patient age, gender, metabolic profile, etc. This will will establish the risk profile for the patient, and then depending on this risk profile, the treatment will have to be designed. The changes in the lifestyle would have to be designed accordingly. The lifestyle, we need to encourage physical exercise, stopping smoking, stopping alcohol, dietary habits will have to change, relaxation techniques, stress management, and of course, ensure that the patient complies to medication. Right. So how do we apply risk profiling for patients? How do we apply that? How do we decide that having this level of cholesterol increases the risk for cardiac disease in a patient? How did we decide this? Or hypertension, for example? Or what amount of smoking increases the risk? How do we decide this, make these type of decisions? So why do we say a cholesterol of 180 is good and a cholesterol of 220 is bad? How do we make this decision? Do people, are babies born with manuals and they tell us there's a manual with the baby and we open up the manual and say this baby should have a normal cholesterol of 180? How do we make this decision? How do we decide that the blood pressure normal is 120 by 80 and the blood pressure of 150 by 90 is not normal?
By study it with for example.
Okay, yes, you're right. The lady is right, but could she clarify it further? Can you please repeat?
Yes. For example, if we have some people have some specific disease, we ask him some question, and for example, blood pressure. When we measure it and see it increase, and we know this level is not normal.
Not normal. Okay, not good. We label that as not good before we label it as not normal.
Yes.
Very good, excellent. So we decide about these criteria for risk profiles on population studies. Yes, one of the most famous population studies is the Framingham Heart Study. Yes, this Framingham Heart Study was started in the 1930s on a group of nurses initially in the States, and we wanted to know depending on the blood pressure, lipid profile, smoking, and diabetes, on how this increases the risk for coronary artery disease in patients. Yes, so our normal levels of the blood pressure, saying 120/80 is the normal blood pressure, means that if a person maintains this blood pressure, then they do not have an associated risk for a cardiac event in the next 10-15 years. That's how we decide what is normal. We have now data on patients in the last, now the Framingham's data collection is still going on. So the study actually became more extensive and it is still going on. So now we have a lot of data telling us that having a cholesterol of 180 or less means that in the next 10 to 15 years, it's very unlikely that one would suffer from atherosclerosis. That's how we decided what is a normal cholesterol. Yes, so we have gone through that process. We have based, very good, this was a very good answer, that we actually look at population studies and we decide that having this range for a metabolic profile or having this measurement for a blood pressure or the BMI is associated with a very low risk. But having a blood pressure, for example, 150/100 and above is associated with a high risk. And that's how we label and create standards for blood pressure, smoking, cholesterol, diabetes, etc. Right? Okay. Now, that's one part of the answer that one part of the answer to the question we asked on risk profiling. So the presence of hypertension and presence of diabetes and the presence of smoking and the presence of sedentary lifestyle greatly increases the risk. But the next question comes to, can we quantify this risk in some way? Can we say that having this amount of, we agree that hypertension, diabetes, smoking, dyslipidemia increases the risk. Can we quantify the risk in the, for example, next 10 years? How do we do that? Can anyone try to answer this question?
Yes, doctor, we have taken the European score, which do a stratification process for the risks.
Very good.
Including blood pressure and other risks.
Very good. So you have already discussed that and you have an understanding that again, this is based on statistical epidemiological studies of the population, and we can actually use this data present in people who had the MI in the next 10 years and they had this level of this cholesterol and this level of blood pressure and this level of diabetes. So we have data now and we can design formulas that will help us to calculate the risk for a patient for the next 10 years, for example. So this is an example of an online calculator that has that is based on data from the Framingham Coronary Heart Disease Risk Score. So you could put in the age of the patient, you could put in the gender, answer the question yes or no, put in the patient's total cholesterol, HDL cholesterol, systolic blood pressure, and is the patient being treated with medication? And you will be able to calculate an overall risk for the next 10 years for this patient to develop a cardiovascular event, right? Okay, so there are different risk assessment tools and you can go online and you can actually use them. Behind these simple looking formulas, there are years and years of data analysis that goes into this calculation, right? Okay, so are we clear about this? This is an example of the Framingham risk score. And you have already done the European risk scoring, and basically this has the factors it uses are the age, total cholesterol, HDL, blood pressure, both the systolic and the diastolic, presence of diabetes and smoking, and you note that this is varying between the male and the female gender. So basically the presence of these factors will help you to calculate the risk predictability for this patient. We would like the patients to stay in the green, and we would like to avoid the patients ending up in the red portion of this Framingham chart. Okay, so this is again this is a European chart, basically profiling the blood pressure versus the presence of cholesterol profile between the males and the females. Okay, so if you have in these charts, you are able to score a patient in green, then that means they have a very low risk of cardiovascular event or death in the next 10 years. Having it in yellow increases is 10 to 20. Having it in red is very significant. So we need to understand that basically this is how you use these risk profiles for a patient that you're seeing in a clinic without an event, and try to find out if they are going to have an event in the future, or a patient who already had an event, what's the likelihood of this event reoccurring in the patient, right? Is this clear? Any questions on how we calculate the risk profiling and how we actually practice risk profiling in the patient? I hope this is clear, right? Okay. Now, yes, please. Okay, I couldn't get it clearly. Is this a question or is it simple? Some interference. If it's a question, the student can repeat it again, please.
No, sorry, I opened the microphone by mistake, Doctor. It wasn't a question.
Okay, thank you so much. So we can go forward. So do you know what saves more life than, what type of therapy saves more lives than anything else? Any idea? What is the single most important intervention that doctors do that saves lives more than any other treatment?
Change lifestyle, for example, exercise.
Very good. So remember, I mean, if someone tells you which intervention by physicians saves more lives than any other modality, and you would be surprised that having a healthy lifestyle or encouraging a healthy lifestyle, it is a single most important intervention that can improve the outcome and reduce and save lives. But do you think it's very unfortunate when we, for example, when we talk about treatment of COPD, chronic obstructive pulmonary disease, what are the students going to jump at? What are the treatments that they will start enumerating? They will talk about beta blockers and short-acting, long-acting beta blockers, yes, steroids, and they will. You will remember the pharmacological intervention. What is the single most important intervention that will help you to treat COPD in a patient? Anyone? We know what is the most important common cause of COPD?
Allergy?
Allergy is different. Allergy can cause asthma, but not COPD. Chronic obstructive pulmonary disease. What is the single most important causative factor of COPD? Smoking. Yes? Smoking is the single most important factor. And what should be the most important intervention in preventing COPD, treating COPD? What should it be? Short-acting beta blockers, long-acting beta blockers, aminophylline, steroids? What should be the single most excellent? And this is something we do not pay too much importance at. The stopping smoking is the single most important intervention proven to help reduce the progression of COPD and help to treat it, right? So the takeaway message is that improving lifestyle is an essential part of any intervention in any disease, right? For example, in cardiac diseases, we could ask the patient to start regular exercise, and the activities, it should be aimed to have the patient having daily limited exercise instead of 3 times a week or whatever. 1, stopping smoking, I mean, we are Muslims, so for us, absolute stopping of alcohol. But if you're working in a American, European context, then it is not very easy to advise people to stop consumption of alcohol completely. But you will want them to reduce their intake. You want them to have a healthy nutrition and control their BMI. You should limit butter intake of margarine, fatty meats, fat dairy products, snacks. At least have 2 portions of fish per week. Daily intake of fresh vegetables and fruits, and maximum of 6 grams of sodium chloride in 24 hours, right? And of course, relaxation, reducing stress, and regular compliance to treatment. Now, if I asked about this diet, can I ask a very frank question to everyone? Who thinks that they're taking an ideal healthy diet? Anyone who thinks that we are all medical and allied and we are health professionals. Can anyone claim that they're taking a healthy diet that has up to 200 grams of vegetables and 200 grams of fruit per day? Anyone can take up this challenge.
I used to before I came to Korea, doctor.
Okay, so you used to do it before you became a student at Salman Raj University. Yes?
Kind of, yeah.
Yeah. Okay, we do have some answers that are being typed in. I'm sorry, I would apologize. I'm not going to look at them, so I require people to please verbally interact. Yes. So I'm sure that it's very few people who can take up this challenge, right? And this is very unfortunate because as physicians, we are the ones responsible to guide people on healthy diets, and it's very few physicians who are following this diet, right? Healthy diet themselves. So again, something that we should self-reflect. Right. Now, who should be responsible for bringing about these important lifestyle modifications? We have the general practitioner, we have the nurse practitioner, we have the cardiologist, we have a cardiac nurse, we have the dietitian, and we have the physiotherapist. Yes. Who's going to be responsible for this lifestyle modifications as a whole? Any ideas? Who are you going to choose between them for ensuring lifestyle modification?
Dietitian.
Okay, so we have one choice. We have a student who believes that the lifestyle modification should be supervised by a dietitian. Good. This is a good choice. Anyone else?
I will choose cardiologist.
You think it's the cardiologist who saw the patient for a few hours after he had the MI. He was the one who did the cardiac cath. He is the one who cured the MI, but he's a very busy doctor, lot of patients. So, okay, why not the cardiologist? What about the general practitioner who actually, the patient went to him with chest pain and then the general practitioner referred him to a cardiology emergency, and later on this patient will follow up with the GP, with the general practitioner. Don't you think he must be responsible?
Yes.
Okay, good. So we do have some votes for the general practitioner. Anyone who thinks that the rehabilitative physiotherapist has a role or is the one who should be primarily responsible for lifestyle modification?
Why not?
Why not?
Maybe
okay,
all
so
of them.
Okay, excellent. Who was the student who said all of them? Can I have the name, please?
Me, Aya.
Aya, okay. I will agree with Aya, and she's made the correct choice. Actually, it's a job that's shared by every health practitioner interacting with the patient, because lifestyle modification is a very difficult intervention. As I said, for a GP to refer the patient with chest pain to the emergency is simple. For a cardiologist to come in and do a cardiac cath, it is a challenging job, but it's very focused and that's it. Dietitian can come in and have one single session with the patient and give him a list of all the good foods and all the bad foods. The physiotherapist can have a single session of bringing the patient back to regular exercise. But remember that to follow up whether this translates into actual lifestyle modification in the patient, permanent lifestyle modification, this is not easy. And when a job is not easy, people tend not to do it, right? And when you have too many people taking the responsibility, what's going to happen? No one is going to do it. Yes? The physiotherapist is going to say it's the responsibility of the cardiologist. The cardiologist say, I'm a very busy doctor. I do a lot of life-saving. It is the general practitioner who has all the time on his hands. The GP says, well, I'm not a cardiologist. I am not the one well-versed with cardiac disease. It is the cardiology unit who should have trained him. and the dietitian says, I'm only going to tell him about the diet. Why should I answer questions on how much exercise and what I should do? Yes. So what's usually going to happen is when you have something, that's being shared, no one does it, right? So actually, basically, it is the team effort, but the team effort should be organized in such a way that everyone should be participating. Why do you think? I mean, one student chose the general practitioner. It's a very good example because the general practitioner has the time and is the one doctor that is most easily accessible for the patient, right? The cardiologist is important because he's saving the life of the patient at that time. And let me tell you, patients are going to be in a very receptive mood to listen to someone who saved their life, right? So that's important intervention for the cardiologist at that time. The dietitian is the one that is qualified to be able to guide the patient very specifically about the type of diet. And naturally, the physiotherapist is the one trained enough to guide the patient on how to gradually come back to regular physical exercise. So do we agree that it's a team effort, but very clear, focused targets should be given to each one of them? Do we have an agreement on this?
Yes.
Okay. So we all agree that it's going to be a team effort trying to deal with the patient as a whole. We come now to the more intimate relationship between the psychology and the heart, right? So we know that patients' stress causes ischemic events, chronic stress as well as acute stress. So let me give an example. That slide is there. Oops, that slide is gone missing. Okay. I'm going to give an example. In 1996, Holland, we actually follow Maastricht. Basically, Holland reached the finals of the European Cup, right? And this was the first time Holland had reached the finals of the European Cup. And because the population is very closely associated with football, even in Saudi Arabia, people are very enthusiastic about football. Prior to the match, actually the day of the match, the number of MIs increased slightly. Yes. And then during the match and after the match, also the number of MIs increased because Holland actually lost that final match. Why do you think there was a surge in the number of ischemic events prior to that football match, during the football match, and after the football match? Yes, please. Anyone? Why do you think there was a surge in the number of MIs during that period? What factors could explain this?
Tension?
So the acute stress probably contributed to the increased events, and probably we could contemplate that there was a heightened level of stress and anxiety that caused catecholamine surge, and the catecholamine surge caused the plaques to rupture and clots to form, right? So we do believe that stress has a very important role to play prior to cardiac disease. What about the stress in a patient who is having an MI? He knows that there is something wrong with the heart and he knows it's something very dangerous. Do you think this patient will be suffering from stress and anxiety during the episode?
Yes.
Very, very good. So that's why you might note that in the treatment protocol with chest pain, we give morphine to the patient, and morphine has two benefits. It sedates the patient and it also reduces the chest pain, right? So naturally during the event, we have this heightened sense of stress, and the patient classically feels that there's something wrong in the heart and he might die or she might die, right? What about after the MI, after the acute event? The patient has survived. They know they've had a massive myocardial infarction and they know that their heart is not normal anymore. And they now have a defective heart and a weak heart, and they're going to live with this. What do you think would be the consequences of this feeling?
Anxiety?
Okay, it's going to cause anxiety, but these are negative feelings, right? And of damaged heart, weak heart, not being able to go back to routine work, not being able to go back to routine life. So that's going to cause depression. Yes, very good. So we have anxiety, we have stress, but classically, if we think of the psychological model, it's very common for patients to develop depression after MI, right? After a myocardial infarction, it's very common for patients to develop depression. who do you think is responsible, and how do you think this depression is going to affect this patient? Do you think a depressed patient is going to be motivated for lifestyle modification?
No.
Do you think this patient will have the motivation to take medications regularly?
No.
Okay, now that makes it very important that we want this patient to be positively involved in lifestyle modification, take their medication, compliance of the drugs, coming and reporting to the physician on follow-ups. And if this patient is depressed, then naturally this is going to interfere with our management of his cardiac disease. And that is the importance of the psychological application of the psychological model. So we need to understand that someone will have to diagnose this depression, and if it is significant enough, they will also need treatment, because that will have a very important effect on our overall management, right? Is that clear?
Yes, doctor.
We also have the role of anxiety disorders. You might have heard of the panic disorder or anxiety disorder. Yes. It classically causes a sudden acute onset of anxiety due to some unknown cause. The patient is unable to pinpoint what caused the anxiety. Along with this anxiety, there are physiological symptoms like tachycardia, tachypnea. Patient can have palpitation, they can have chest heaviness, and anxiety panic disorders is one of the differential diagnoses when a young patient presents with chest pain to the emergency, right? So this panic disorder or anxiety disorder can be a differential diagnosis in young patients for acute ischemic events. Many times these patients are diagnosed with an acute MI or acute coronary syndrome, they're admitted, and later on they're found to have normal ECGs, normal cardiac enzymes, and they find out that this patient actually had an anxiety panic attack. And the diagnosis of anxiety panic attack increases if the patient has any other psychological background. If they have agoraphobia, social phobias, they have obsessive compulsive disorders, they have post-traumatic stress disorders, they have depression, they have hypochondriac. So if a patient already has some psychological problems, the risk of anxiety panic disorder increases, and this can be a differential diagnosis for acute chest pain, right? Okay, so we need to understand that again, cardiac diseases can be caused by stress and anxiety, and cardiac diseases can cause stress and anxiety after they've occurred. And similarly, cardiac diseases can be mimicked by anxiety panic disorders. So do we understand that psychology again has got a very close relationship with cardiac disease, both in causation, in mimicking cardiac disease, and in the stress and anxiety being caused by cardiac events? Do we understand the correlation between them?
Yes.
Yes.
Okay, excellent. So we understand. So we have an example of a panic attack. Mr. Albert, who's 54 years old, he presents to the cardiac emergency with chest pain. There is shortness of breath. Okay, there is this is a Dutch word for palpitation. There is sweating, mild sweating, but the patient has normal blood pressure and ECG, and the enzymes are also normal, right? What diagnosis you're going to have with a patient who has normal ECG, has normal cardiac enzymes, has chest pain, and there is shortness of breath and palpitation and sweating. And this patient is known to be hypochondriac. The wife who's with him tells you that he's always, worries about things, is of the anxious type, and he easily gets stressed. Now, this background helps you to diagnose him with anxiety panic attack, yes? Would it be enough to send him home and just tell him that you don't have a cardiac event? Yes? Would this be enough?
No.
No.
What else would you like to add to this patient? Just send him home, or?
To calm him down and to reach a level of relaxation, and then to manage
Okay.
panic attacks so
Yes.
it doesn't happen again.
Very good. Remember that diagnosing psychological explanations for any symptoms, this is usually a diagnosis of exclusion. So you will first make yourself confident that this patient has no indication that they have a cardiac event, like an abnormal ECG, cardiac enzymes. You will evaluate the patient. After that, you will make this diagnosis, but it will be a provisional diagnosis, and you would like to have it confirmed by a classified psychiatrist. The patient will need psychiatric referral. right? And they will need formal help, right? Now, at Maastricht Emergency, Maastricht Academic Hospital, people presenting with non-cardiac causes of chest pain as psychiatric causes, the percentage has been from 20 to 50%. And these patients were presenting to the emergency as if they had a cardiac event. The patients were thinking they had cardiac problems, but 20 to 50% of these patients actually had psychological disorders. On the other side, 13% of these patients were diagnosed initially as acute coronary syndrome and were admitted to the CCUs. So it's both ways. Many patients with anxiety panic attacks present to the emergency thinking it is cardiac events, right? And they are worked up at the emergency level, and to the relief of the patient and the physician, they are told that they don't have cardiac events. But 13% of these are wrongfully admitted to the CCU thinking it's a cardiac event. What type of a patient do you think will end up in the CCU? Can anyone give an example of a patient or the characteristics that might have a panic attack but still be mistaken for a cardiac event at an academic hospital and end up in the CCU? What do you think? What combination of characteristics made this patient end up? Okay, now classically, if it's a student, young patient, and they have a stressful context, they have an exam coming up, we will not admit this patient to the CCU because they have a context for their stress, and we will believe that this chest pain is due to an anxiety attack. What about a 55, 60-year-old male who is diabetic, who is hypertensive, who is dyslipidemic, smokes, and has borderline normal ECG? The cardiac enzymes are initially normal, but the symptoms are somewhat classical of chest pain. Would you like to take the risk of sending this patient home? Or would you like to observe him in the CCU for a few hours?
Observe it.
Very good. So the classical patient that will have an anxiety panic attack, but would still be kept in a hospital for prolonged observation will be someone who has more risk profile for cardiac events. Maybe they're elderly, they have got dyslipidemia, hypertensive, smoking, they might have non-specific ECG changes. These are the patients who, despite later on finding, it will be discovered later that they have anxiety and panic attacks, but these are the patients classically who might be admitted wrongly in the CCU for observation, right? Okay, but this, at the end, we will not say it was a wrong admission because you were acting in favor of being cautious, and you had some reasons for admitting him. But to your relief, after a few, overall evaluation in a day or two, the patient was found to be having non-cardiac pain. Okay, so we need to understand that psychology of people is very closely related to cardiac disease in multiple ways. Now, coming to cardiovascular disease, which gender has more cardiac events, males or females?
Males.
Okay, so and is there a difference in the age? So do you think that women below the age of 50 before the menopause have got a very much reduced risk for coronary artery disease as compared to their counterparts in the same age group?
Before age of 50, for women it's less than none, but after menopause it's more than.
The risk profile becomes very similar, right? Okay, agreed. Now, unfortunately, the perception is that in physicians, they tend to think that males and females after the menopause, they still tend to stick with the idea that if a female is presenting with chest pain at the age of 55, it is less likely for her to be having an MI as compared to a male, which is not a very correct approach. Ladies after menopause, very rapidly, they become very similar to males in the risk for coronary artery disease. And the cardioprotective effect is only before they get the menopause because of the estrogen, right? This is one thing we have to keep in mind. The other thing is gender differentiation. It does have an effect on the way the patient presents, right? Men and women do not present with the same type of symptoms in a myocardial infarction, right? Men present with more specific symptoms, localized chest pain and sweating and palpitation, whereas females present with more vague symptoms, right? Okay, so we need to understand that women, they present differently, and that is why women might be diagnosed less frequently with an acute MI as compared to men, because they present with less specific symptoms, more vague symptoms of the fatigue, just being unwell, generalized weakness as compared to men. And we need to understand this difference between males and females as when they present to the physician with suspected cardiac events. So 2 points to take from this slide. One, menopause, pre-menopause, women are relatively protected, but after menopause, please remember that this protection does not last, and the cardiovascular risk factors become very closely relatable with both genders. Secondly, we need to understand that males present with more overt, clear symptoms of myocardial infarction or acute ischemic events as compared to females, who might present with less. So, in which gender is it more likely to miss the diagnosis of MI, in the male or in the female?
Female.
Yes, we need to understand that it's more likely to miss the diagnosis of acute coronary syndrome in females as compared to men when they present. Moreover, we need to understand that this is related to the biology. Women, when you do a coronary cath on females, if they have coronary artery disease, they tend to have plaques which are more diffuse and more distal, whereas men tend to have atherosclerotic plaques which are more focused and more central disease. So more coronary artery disease or to have distal coronary artery disease?
Proximal.
Yes, it is more dangerous to have proximal because localized lesions in the proximal will completely close the vessel at its origin. Whereas females, they tend to have more diffuse disease. And the reason again is atherosclerosis is a gradual process that occurs over the life of the patient. And estrogen tends to protect and distribute the atherosclerosis in a more diffuse way as compared to in the males. That's one. Secondly, estrogen makes the cap of the plaques more stable. So when the atherosclerosis is developing, the fibrous plaques, their caps are more stable and they rupture less because of estrogen, right? So we know that there is a concept of microvascular angina. Does anyone understand what is microvascular angina?
It's that the blood flow in the heart coronary artery is going very well, but the problem is the microvascular arteries
Very
are
good. So
dysfunctional.
very good. So you have very small vessels that have microvascular, atherosclerosis, and the ischemia is there, but it is due to peripheral vessels in the heart, very small vessels that are atherosclerotic. Now, microvascular angina classically occurs in the females. It's very uncommon in the males. So patients do present with chest pain. They have ECG changes, but when you do their coronary caths, their major vessels look relatively normal. This does not happen in males, right? So microvascular angina is more frequently in females. We need to remember this. There is a professor, Dr. Angela. She was a professor in cardiology. A female professor in cardiology is not very common. She's a consultant cardiologist. And she says that do not think of women as smaller men when you deal with them in a cardiac way. So it's not, women are not a smaller copy of the men when you approach their cardiac disease. They do have differences in the disease progression, in the presentation, and somewhat in the management, right? Okay, right. Now, we will go to, I think we can skip these slides. You can go through them later on. Now, a patient has had an acute myocardial infarction, and this patient was referred from the general practitioner to the cardiology unit. The cardiac unit did a cath on him, and they salvaged the coronary vessels. The patient is stable, has made an uneventful recovery, and the hospital stay was 1 week, right? Now this patient is very happy about the treatment in the hospital, and the reason is because they survived without a complication, and the patient feels relieved that they survived. Now after 1 week, the patient is going to be sent home. The question that this patient is going to be having is, what are the things that I can do and what are the things I cannot do once I go home? One, Secondly, the patient is concerned about when can I return to my work, right? Naturally, this is a very valid question, right? So, and how much time I can take off as, medical leave, right? Okay. Now, this is the concerns of the patient, right? The wife has concerns, and she's the attendant, and she says, okay, I mean, what type of food am I going to prepare for my husband, right? And this patient is easily irritable. What can I do to make him less irritable and less anxious, right? We, unfortunately, the lady says, we've had a very sedentary lifestyle and we do not go out often on walks. So how frequently can I take my husband out for walks, regular places, right? Yes. And the patient says that, I've tried, I am a smoker, I've tried quitting, but I've not been able to quit. What can the doctor do to help me quit this habit once and for all after this cardiac event? So who's going to take care of all these questions? Yes, there is a concept of cardiac rehabilitation. You're bringing, after an acute event, you're going to bring the patient back into normal life. And this is called rehabilitation. And the concept of cardiac rehabilitation is there. And how do you bring a patient back to their pre-cardiac event levels of exercise and functionality, right? And this basically cardiac rehabilitation is done by, physiotherapists, nurses take part, social workers, psychiatrists come in if there is any, problem with depression, anxiety, social workers, occupational therapists might guide on the occupation, on how to modify the occupation, and lifestyle improvement, but the overall supervision would be by the treating physician, right? So we have the concept of cardiac rehabilitation, and this cardiac rehabilitation plan will be made according to each and every patient, their BMI, their age, gender, as we talked about, looking at the biological model, applying the social factors. What if this patient has got a flat at the second floor? Can this patient climb stairs? There is no lift in that flat. What to do regarding this? Who's going to be guiding the patient on maybe trying to get a floor at the ground level, a flat at the ground floor for some time, for a few weeks, or to shift there, who's going to give this advice? So each patient should have a tailor-made rehabilitation plan, and this rehabilitation plan is made by the cardiac rehabilitation team, which consists of multiple players: physician, physiotherapist, dietitian, social workers, occupational therapists. So actually at Maastricht, the team meets, right? They meet and they sit together and they look individually at a patient's background before they design this rehabilitation. Do you think this happens here in Saudi Arabia anywhere? Yes? Anyone has any idea?
Where, doctor?
Do you think that this multidisciplinary approach of bringing the patient gradually back to normal life, as in the concept of cardiac rehabilitation, is this concept practiced in which the whole team meets together and they look at the patient's background, information, context, and then they design a rehabilitation plan for him or her?
Yeah, I hope so, inshallah, it's implicated here.
Yeah, it does apply partially. We have the example of the Prince Sultan Cardiac Center. They do have a cardiac rehabilitation team. Unfortunately, it's not as extensive as the team at Maastricht. For example, in the rehabilitation team, we have cardiologists, rehabilitation physicians, occupational physician, cardiac nurses, therapists, physiotherapists, social workers, psychologists, occupational experts, psychiatrists. So it's not only psychiatrists, but psychologists. These are two different specialties. Patient representatives who are going to look at patient rights, insurance physicians, because they are going to be responsible looking at the payments, how the patient going to take care of the treatment cost, and we have general practitioners who are in touch with the patient. So you have a very extensive rehabilitation team, and this is headed by usually the consultant cardiologists, right, who act as the heads of this. And this is a model, again, we need to understand, this is a model, again, applying the biological, psychological, and social aspects of the disease. All of these people, some of them are looking at only the biological aspect, like the cardiologists, they're opening up the vessels. We have psychologists who are looking at the psychological aspects. We have occupational therapists and occupational experts helping with the social aspect. So we need to understand that at the end, again, going back to what we started discussing, we need to apply the biological, psychological, social model, and this will mean we'll be, delivering not only the cure approach but also the care approach, right? Yes. So, do you want patients who believe that they're being cured for and cared for, and that will require that the patient is looked at in the biological, psychological, and social model? Are we clear about this now?
Yes.
Okay, I think I will stop here with the last slide. So we have something called as the broken heart syndrome. It's actually Takotsubo cardiomyopathy. It's got a fancy name of Takotsubo cardiomyopathy. And what actually happens is, in these patients, they're usually younger patients, and they've got some acute emotional stress, a massive emotional problem, and that causes a part of the left ventricle to develop localized cardiomyopathy, and this cardiomyopathy causes part of the left ventricle to become dysfunctional, right? And this is diagnosed as a broken heart syndrome by physicians. And maybe this is the reason when people have some unfortunate events, like the death of a beloved person in the family or a bereavement. I don't want to relate it to simple, broken heart syndrome, as in, romantic broken heart syndrome. It's not just that. People with severe psychological trauma can undergo that. So we need to understand that psychology or a psychological aspect of a patient can affect the heart acutely as well. Okay, and it might make interesting reading if you go home tonight and look up what is a broken heart syndrome, right? Okay, I will stop here. Are there any questions?
Is this condition congenital?
No, it's not congenital. This occurs in young people, usually, who have normal hearts, and they undergo excessive acute emotional stress, like, as I said, bereavement in the family, a loved one dies, the parent dies, or a life partner dies, or we could make it more, we have the typical broken heart in case of, we talk about romanticism, in which people get a broken heart because of that. Maybe it's not as acute as such, but this doesn't have to be congenital. This occurs in a pre-existing normal heart, and it's an example of how excessive psychological trauma or emotional trauma can acutely affect the heart. There is a new field called neurocardiology, right? And it might be also interesting to look at this field. It's just developed in the last 5 to 7 years, and there have been evidence, people who have undergone a cardiac transplant. Yes, so a patient received a cardiac transplant from a donor who died. The patient had some transfer of feelings from that transplant donor. So they had certain emotions and feelings that were transferred to the recipient. Can anyone think of an explanation for that? We know that for us, our basic understanding is that feelings, emotions, and psychology, it arises from the brain, from the CNS. Yes? But now evidence is piling up that tells us that, for example, a patient had certain liking for someone or certain liking for certain foods, and after getting the transplant, they develop the same likings and the emotions as the donor had. Any explanation for this that comes to your mind? Any possible explanation?
Maybe there are memory cells in the heart.
Well, they say that.
Neuronal cells.
Very good. So can I have the name of this student who told us about the neuronal cells?
Azadeen.
Azadeen. Okay, this is a very good answer. You see, the heart has got a conduction system, which we believed in the past that it was only utilized for conduction of action potential, right? But now studies are coming up that show that this conduction system actually works as a as a collection of nerve tissue. It is conductive tissue. It is very similar. The conduction of the action potential is exactly what happens in the brain. The brain is a network of fibers that transmits action potential. So people are now coming up with this field, and there is evidence that supports it. There is actual evidence that supports this, that the heart could also be the seat of feelings and emotions. Now, I have a question. Traditionally, our deen and our religious teaching not only in Islam but all the other divine religions also tells us about, always keeps on mentioning the heart as the center of iman and faith and feelings. Yes, in the Quran we have multiple ayats that cite the heart being the seat of faith and iman and emotions, right? So maybe it's interesting if you could look this up as self-directed learning. Okay, it's possible now that there are studies and design studies that are going on that might tell us that the deeper emotions, the deeper feelings like faith in someone or love for someone might actually reside in the heart and not in the brain as we have traditionally believed, right? So maybe you could look up the field of neurocardiology. This is an upcoming field. Anyway, I will stop here. Thank you very much. It was a very enjoyable interaction. There was a lot of participation from the students. The only request would be, because it's a big group, I would request people